said slides weren't necessary, but I put some together just to kind of organize my thoughts also. I can. Okay. So hi everybody, I'm Dennis. I am one of the global surgery fellows. I'm also a general surgery resident at UCLA. And one of the things I've been working on has just been looking at the implementation of a checklist for the EMS service pre-hospital care in Rwanda. And this is just looking at some retrospective data. And so I certainly haven't been involved in this project for a long time, but kind of understanding the history of it. I understand that there has been, nearly a decade-long kind of move towards quality improvement for pre-hospital care in Rwanda. And starting with this paper, they were able to implement this continuous quality improvement program with the SAMU or the EMS service there, and kind of through a series of regular, whether they be weekly or monthly, sort of audit and feedback meetings, talking about specific kind of quality measures that had been agreed upon, that being the sort of quality improvement intervention. They were able to show, a significant improvement in each of the 5 kind of quality measures for specific pathologies for trauma over a year. And so you can see this pretty impressive improvement for all of these specific conditions. And then, as I understand it, that sort of fed into an R21, investing further in this idea of quality improvement for pre-hospital care in Rwanda. And then for a number of conditions, not just traumatic conditions, but including medical conditions, working to sort of adapt protocols and checklists from the US to kind of guide and measure quality of care provided in the pre-hospital setting in Rwanda. And this was kind of looked at least in one publication, in 2020, and this I've talked about the very beginning, the pilot data for this. And so there were 8 checklists that kind of were implemented at the end of 2018. And this was just a study of the pilot data, looking at over a month, how many patients were seen who kind of met the criteria for specific pathologies, and then how often each of them had a checklist item or assessment kind of completed. And so the first checklist was for extremity injury. And you can see that there were over 160 patients with extremity injury in just a month. And for, most of these criteria, the percentage of compliance or adherence was quite high. What I did notice was that, unsurprisingly for the rest of the pathologies, the numbers were fairly low, which makes sense for a month of data. But that's kind of where the subsequent analysis comes in. But anyways, the second checklist being for TBI, and then for sort of general altered mentation, and then for hyperglycemia, as well as hypoglycemia, and then postpartum hemorrhage, and there being specific actions to take in that situation, and for respiratory distress among adults, and then respiratory distress among the pediatric population. So this was sort of where I entered, and then subsequently I have been able to look at data both prior to the implementation of this checklist. So I've been able to look at data from prior to the implementation of this series of 8 EMS checklists, So, and this period, to be honest, I can't exactly tell you why specifically we selected this period, but this is the data that's been available from March to July of 2018. Like I said, the checklist seems to have been implemented starting in December. And then immediately afterwards, another 6 months of data. And then, as I understand, there were some. Gotcha. That's just the most complete set of data available for the prior period. And then I understand there were kind of issues, obviously, with COVID and everything. But this sort of second collection of post-implementation data that's sort of a few months into COVID in Rwanda, as it seems, sort of the third period. So looking at that, the next few slides are pretty, they're kind of busy, but I think it's easiest to understand the trends in the data if we just take each checklist one at a time. And so if you'll bear with me, the first checklist, again, was extremity injury. And so the ends for these are now a lot bigger because these represent like 6 months of data at a time. You can see that each of these is sort of a checklist assessment item like we had done before. And then I've highlighted in green anytime the sort of checklist compliance or adherence increased compared to the prior period. And then I put an asterisk anytime that sort of chi-square analysis revealed that this change from the prior period was statistically significant. I didn't do that for all of the tables because I ran out of time, but at least for this table, I think we can spend a fair amount of time here. And I think a few things really have jumped out to me, namely in terms of, I think, the main tenets of trauma ABCs. They already were doing quite well in terms of having an airway, a respiratory, and a circulatory assessment recorded in the sort of EMS database that they were using prior to the checklist. This is 97 is obviously quite high, and that's only improved since checklist implementation. I think maybe along the line of expectations, and certainly in accordance with the pilot data, more patients who need oxygen were getting oxygen, at least in this cohort. But then somewhat funnily, and this trend is sort of mirrored in a lot of the data, and this is why I put this red box here, is just that the patients with a blood pressure below 100 millimeters of mercury were supposed to get a bolus of either saline or LR. And for whatever reason, it looks like that compliance in the data went down after implementation of the checklist and then kind of rebounded during this later period. The other limitations, of course, with the checklist kind of compliance, using EMS data that doesn't necessarily track to it directly, we're not able to say, how often were they doing these things before the checklist was implemented. And then these sort of fields, I don't feel super strongly that, that we know for sure, for example, that there were 12 patients with a pulse extremity, and they only, reduced this presumed fracture or, displacement 3 out of those 12 times. Like I'm not sure, obviously, how much of this is just data issues. But I think that the key takeaway here is really in this, management of hypotension scenario, and maybe it being somewhat surprising as far as this trend towards less frequent management and then back towards more management of that issue. But this is kind of the sort of just the general outline of the first checklist. And then moving on to the second one. So this covers any patient with a traumatic brain injury, and I guess I have to erase all of the old ones.
You got it? Okay.
Here again, I think it raised some questions in my mind that we're still sort of sorting through and trying to understand. Again, ABCs, okay, that's looks good, right? But in these specific scenarios, when a patient has a GCS below 8, it looks like they were less frequently giving oxygen as compared to prior. And then that actually worsened, a year later. And again, in the general scenario where patients were hypoxic, people were giving oxygen more frequently, which is great. And then again, we see that trend that had been observed prior, where you have hypotensive patients who are maybe not getting fluids as often, but then are getting fluids more often down the line. And sorry, this is arranged this way again, but again, the general principle of if you have a patient with a GCS below 8, in this setting, we're recommending placement of the cervical collar. That seems to have been happening less frequently with time. And then the rest is sort of not as frequent. And then okay, I guess most people can hear me. So yeah, again, I think the main kind of questions this brought to mind for us was really about, what is going on with the management of hypotensive patients, and then sort of management of patients who may be unconscious. And so I can kind of get to some hypotheses for that later. Okay, great. And so that is for the TBI checklist. And then there's, of course, another checklist that sort of deals with general medical, I'm not sure how these definitions are placed, aside from I'm using kind of like the free text chief complaint in the data. But there's another segment of the population that's altered mental status without having a traumatic head injury. There's this kind of stroke scale that was included in the checklist sort of recommendations that initially was being complied with very frequently and then dropped off significantly. I think this of all of them sort of makes the most sense, although I haven't obviously investigated this further, but I think intuitively, use of this maybe could drop off with time. But again, here we see the general trend again with the hypotensive patients that compliance increased, although of course these are not large ends that we're dealing with for this specific condition. And then the rest of the checklists are not as large in terms of numbers. So I don't want to dwell on them too much. I think again, you see with the hyperglycemic patients, they're getting the ABCs checked more frequently. They're getting oxygen more frequently. Again, there's not a ton of them, but they're not maybe always getting fluid resuscitated as frequently, although that increased with time. And then management of their hyperglycemia, which would seem to be the key aspect of this checklist, with this segment of patients wasn't really happening as much, curiously. And then, of course, the inverse of this, general trends are the same with the hypoglycemia checklist. With time, that ABCs are being assessed basically all the time. Oxygen is being given, glucose is being checked, thankfully. And then it's hard to say what the practice was prior to the checklist implementation, but it doesn't look like in every situation of hypoglycemia, they were necessarily either giving, the recommended treatment, or recording that they gave the recommended treatment. And of course, that's the limitation of all of it. And then, sorry, I didn't put it here, but the differentiator here is between, if their mental status allows for oral intake. But these, have not been my focus of my thinking, at least. Postpartum hemorrhage, the numbers certainly have increased in terms of, slightly increased in terms of eligible patients. And again, they're getting their ABCs assessed. I don't know, if there's some nuance in the checklist that has been missing in terms of my understanding of it, because it basically said, perform uterine massage for all patients, but that hasn't been frequently performed until this post-COVID period. And then the checklist also says just to, regardless of blood pressure, give fluids, which again were not happening super frequently, but then did increase in frequency later on. And then the checklist again, kind of black and white, says give misoprostol, which, I don't know if there's some nuance in the practice that I'm missing, but that doesn't look like it happened. And then, it does say if bleeding is refractory, give TXA. It's hard to know the N for this in terms of the total patients with refractory quote unquote bleeding based on the data, but that was given at least a couple times as far as I can see. So these are the more nuanced checklists here, obviously. And then for the respiratory distress population, again, we see general trends that are reassuring in terms of ABCs and giving of oxygen. This checklist has said, just if you have a patient with respiratory distress, give them salbutamol. Again, that didn't really seem to be happening that frequently, even after the checklist implementation. And then in these specific scenarios, providers are instructed to do specific things. But unfortunately, it's hard to tell from the data, how large that denominator is, because there's not like a whole sequences of care being reported. It's kind of like their mentation is this. But at least, there were patients getting Niagara epi and getting more definitive airways placed. And then the final one is just for sort of pediatric patients, and doesn't stand out that much compared to the adults. Again, ABC of oxygen happening very frequently, the salbutamol not being done a ton, and then hard to know about the other adjuncts. So in summary, I think we can really distill this to the common steps that obviously were happening in basically all of the checklists, and look at specifically at those. The reassuring, positive aspect of these results is obviously that they've gone from, or over these periods, the EMS providers were more consistently checking the ABCs, which, I think we can all agree is a good thing. And similarly, when there were patients with hypoxia, they seem to be more frequently giving oxygen. And then sort of interestingly, although these numbers are not huge, this kind of previous standard of management for giving fluids for hypotensive patients seemed to have dipped significantly, but then bounced right back. And it's sort of unclear if maybe attention was being drawn from another aspect of the checklist, or just people were still doing these things and maybe were more used to doing them and didn't feel it as necessary to record these things as they're doing them. So I think that has really brought to mind, several questions for me. which I think specifically, as I've been saying, this management of hypotension, because it's hard to imagine, providers either forgetting, what to do or being less aware of what to do with this kind of really significant quality improvement intervention being performed. And similarly for these altered patients, it's pretty black and white as far as placing a collar or giving oxygen in certain situations. And so certainly I have been just pondering, how much of this is just limitations of the data, people maybe having checklist fatigue for this, immediate post implementation period, not wanting to, not being able to record things, wanting to record things, seeing the point of recording things, as opposed to what they were actually doing in the real world. Of course, it's hard to know. And then if it does represent people, I guess worst case, if this data is all exactly reflective of real world practice, and the checklist actually was associated with fewer patients getting fluids, does that sort of represent an unintended consequence of the checklist, where maybe this cognitive burden introduced by having to remember to give salbutamol for respiratory distress or something, did that cause people to sort of have less of an ability to remember to give fluids? But I think, a lot of these questions will hopefully be answered by, understanding the checklist user experience. So we're going to be speaking to some of the EMS people tomorrow, and I think that will help really understand these trends over time, hopefully. And then I think another thing I've been pondering is just, the potential use of time series analysis, or just looking at data month by month rather than these, very large, wide periods of time to see, with this, for example, this period, does this represent like 52% of patients the entire time getting fluids, or did it start even lower and then go up with time, or the opposite? So I'm curious about that, and if we'll be able to elucidate things by breaking down the time points even further. And then finally, obviously it would be great to associate with this with outcomes. Of course, in the pre-hospital setting, we're not going to have a lot of meaningful things with that, but I'm wondering, if we can kind of take some of the time data and say, did patients kind of get transported or fully assessed and transported more quickly through the use of these checklists? So that's kind of just more secondary analysis that I need to explore with the data. But that's all I have. So open to questions and going back to any of the specific checklists, because I know it was a lot of information.
Thanks, Dennis. Can you just go back to one of the checklists? I don't know, pick one. Yeah. So great, thank you. This has been a big lift, so I really appreciate you working on this project, which we've struggled with for a couple of years in Rwanda, in part because we did we did a bunch of training in 2018 and into 2019, I think, and then we implemented these checklists. And then there was an Ebola outbreak nearby, and there was a COVID outbreak the following year. So really, it was hard to collect data. It was hard to keep track of data. And so I don't know how to interpret some of these things, aside from saying, I wonder if we should look at, especially the middle time period, a little bit more, and look at some of those cases a little bit more. Like, for example, looking at these 27 cases to kind of truly see if only 11 got fluids. That may be relatively easy to assess from the records here, potentially. So one is, I wonder how much of it is data error because it was pretty chaotic time. And two, I wonder if, it could be accurate just because it was chaotic time as well. And then with the worldwide emphasis on everything to do with respiratory things, the respiratory things went up easily post-COVID, but that took a toll on everything else. And because the focus is always respiratory on anyone, that there wasn't as much sort of thought going into some of the other things. Those are sort of the main thoughts I had looking at this data, but it seems to me that we need to dive into some of these charts to some extent to kind of corroborate that it wasn't just data capture that was erroneous. But that's what I have. Does anybody else have any comments or suggestions? Do you understand what it is that we were trying to do? Because we're gonna have to write this up and explain that. And if we're not able to explain it clearly in this format where we have time to discuss it, then we need to work on our story a little bit more. So thoughts, questions from others?
Well, yeah, actually, I wanted to ask you, like, what were some of the barriers that you observed during the project in those items where the implementation were not as higher as expected? Like, what were the reasons for having a low implementation, for example?
Yeah, I don't know, because all of this is sort of retrospective over a large period of time. So we don't actually know. Our initial goal was to do month-to-month feedback and actually do some qualitative understanding. When we first started this project with sort of the minimal trauma checklist that Dennis showed at the very beginning, that's what we did. And we found things like, oh, the oxygen usage this past month was lower than the previous month because all of a sudden, there was not oxygen cylinders available that month. And so we that could be managed with additional troubleshooting as the data collection was going on. And so they would have that discussion and say, oh, remember that was that week when we really couldn't get any oxygen cylinders. Oh, that explains it. Oh, and then the leadership would go back and say, oh, we need to work on this some more. And so the next month the numbers would be better. And that was how it was before this project. And it's actually, if you go back another 1 or 2 slides, Dennis, it's that one. Yeah, in this project, that's what we had learned in that. And so that's what we had hoped to do across more conditions. And we had picked conditions that were not just trauma. This is just specifically 5 indicators for trauma. And we thought, well, if we could do it for trauma, could we standardize care for a lot of the other high acuity things that would potentially lead to morbidity and mortality? So whether it's stroke or respiratory distress, things that could kill someone, could we more easily standardize that care? But I don't know that we showed that we could do that, despite attempting. I think we have to go back and look at some of this data a little bit more to see, because this was a lot more consistent. This initial project was a lot more consistent meetings, whereas the other one was without that consistent meeting. So if you didn't have somebody telling you what the data was every month, then maybe you wouldn't pay attention, maybe you get distracted a whole lot easier. There's no oversight to say, hey, you're not giving fluid boluses, though it wasn't that oversight. But maybe the oversight improved with COVID, and that's why we see this, this improvement and this improvement. Sorry, I can't do this on my little mouse pad. Maybe we see that improvement because over the course of time, over the COVID era, there was a lot more oversight, and we're looking at this information more closely. So maybe that's why there's improvement there.
Okay.
So I don't know. I think that those are the questions that we have to ask. And we had changed the checklist also between pre and post, so between period 1 and period 2, to be better at capturing the data, which is why a lot of the checklists have better data collection after the first period, because we had tried to set it up so that we're better. But there's still gaps, you know. Like if there's bleeding, applied direct pressure, well, nobody indicated anywhere on the checklist that there was a lot more bleeding that required pressure. Or pressure applied for bleeding, or any sort of text component like that.
I see. And can you describe like maybe some strategies during the implementation phase? Like how were they implemented? Did you perform any like meetings, weekly meetings, monthly meetings? Like
Yeah, so there were several sessions with short courses, kind of like ATLS type courses, that we ran over the course of the year for every kind of group of conditions. So there was a 2-day trauma course, there's a 2-day medical emergency course, there's a 2-day pediatric course, there's a 2-day obstetric and neonatal course. And then all of these checklists were created and then distributed, and they had pocket cards to carry. So the most common conditions had some standardized care. And then there were more complex, more detailed checklists and materials for a couple of dozen different conditions that they wanted to standardize. We only measured these handful of conditions. They wanted to standardize a lot of care for a lot of other conditions, because they felt like standardization was poor and it needed to be improved, because all of the staff, the way they're trained is they're all clinical staff, like nurses and nurse anesthetists. Nobody has EMS specific training. So this is the first time to have EMS specific training for all of the EMS team. And so everybody was on the same page of what content they needed to know. And then they had materials to go along with it, which is why it's a little confusing to say, why did the percentage drop off after the checklist implementation? Because we've done a lot of education, a lot of standardization. And so I wonder if how much of that is data quality related. But without looking further into the data, we don't know. This is the first time we've actually analyzed and looked at this data. So
yeah.
Comments from anybody else? Suggestions from anybody? And one of the things that's starting actually this week, and I'm actually in Rwanda now, one of the things starting this week is that there's a big grant that is coming from the UK government to help with trying to standardize this field care. So when the ambulance team gets out to the patient in the field, how do we standardize the decisions they make? We gave them checklists and we trained them on standard of care, but could we actually give them some other decision support in the field? So even knowing that this is sort of the baseline now is useful, and to kind of know what did or did not work. It would be useful for that project to know, to say, this is where we need to put in time and energy to be able to give that appropriate reminder, perhaps, like, hey, you put in these vital signs, do X, Y, and Z. So there are prompts to actually deliver care, maybe. But those are some of the things that we need to think about in the upcoming years of how do we ensure that we're providing care. So we'll see. Other thoughts from anybody else?
I just wanted to say one more comment. I remember last year I was part of a project where we implemented a protocol called Bootstrap, which is for TBI management. And so we tried to implement Bootstrap in 3 different sites in Colombia. And so we collected pre-implementation data, but we didn't have the chance to finish the project because of different reasons. But we discovered that, well, actually, while we were implementing the Bootstrap protocol, we We even created WhatsApp groups with the nurses, with the physicians. We did virtual meetings with them. We even created a quiz to see if they were actually reading the protocols. We printed huge algorithms and put them in the hospitals. We sent it to their cell phones, so they always had access to that. But one of the things they said is, this algorithm is too complex. We cannot implement this. So it looked like it's a basic thing. Like you can say, you just have to follow the algorithm, but if the algorithm looks super complex, then they will not follow that. And that will, of course, affect the implementation and the post-implementation data.
Yeah, no, that's a fair point. And that's part of the reason why we tried to keep this fairly minimal, but it's hard to say that and maybe it still wasn't minimal enough. I don't know, but that's a great point. You know, the users and the degree of complexity that they have to juggle when they're also dealing with sick patients, or, you know, in the middle of the road, there's a limited amount of capacity for them to do various things, or even on the back of the ambulance driving to the hospital, there's a limited amount of capacity of what they can do under those environments. Even if they have materials to refer to, they often can't necessarily refer to it. So yeah, so I think that's a good question, and I'll just respond to Dennis and say that was too complicated. That protocol is too complicated.
Sorry, it was, what was too complicated?
Sorry,
Yeah.
Gotcha.
So despite a lot of it,
It's a lot of flowchart boxes, as I recall.
yeah, actually the Bootstrap protocol uses a lot of colors and like many specifications, but it looks like they prefer to use the BTF guidelines instead of the Bootstrap protocol, which is funny because the BTF, the Brain Trauma Foundation guidelines, were made for, well, mostly for high-income countries, and some of the countries cannot use the BTF guidelines. However, at least in Colombia, we don't use the Bootstrap protocol. And yes, they are trying to rewrite the Bootstrap protocol so it is easier to implement it. And we are trying to also understand what they use, if they use national guidelines, if they use the BTF guidelines, like whatever guidelines they use, and what do they need in order to, like, basically, are you implementing these guidelines, yes or no? And if not, why not? Is it because of lack of resources? Is it because of like whatever reason? So we are trying to understand that first, and then we will try to reorganize another protocol that is easier to implement.
Yeah, it's fantastic. This is why we have to sort of learn and share from each other, so we can discuss the challenges and discuss the solutions.
Yeah.
So that's fantastic. It's great to hear. Some of you were, I don't know if probably most of you were not here when Dr. Rubiano spoke last year about Brain Trauma Foundation guidelines and traumatic brain injury guidelines in low and middle income countries. And he, big group, were creating them across Latin America, and Laura was a key part of that. So yeah, fantastic. Yeah, so that's one of the current challenges, is finishing up this project and seeing how do we interpret this data. And now that it's been over a significant period of time, it's really hard to go back and necessarily get a lot of detail, and it's hard to get a lot of detail anyway from the amount of information there is in the chart. We'll need somebody to sit down and look through the chart and see what can be discovered for each of these patients, and try to make sense. You know, is it simply a matter of transposition? When they say this person received something when they didn't receive it, or they said that it didn't receive it when it did receive it. So maybe the answers were exact opposite, and so that's why it looks very low, where really it maybe is supposed to look really high. I don't know. So we'll have to see what we can do with that. Comments or thoughts or suggestions from anybody else?
Sorry, I lost my audio also during that portion of the talk, but I was wondering, what was the method for, I know it was retrospective, right? But what was the tool for collecting all the data?
Oh, that's a great question. So they have an ambulance run sheet that they use for every single patient. And there's been a standardized run sheet for many, many years, for the last decade. We modified it once we created these protocols, we modified it to try and capture these variables better. And so that's what's in use even today. And typically, they literally have books and books of all of the ambulance sheets for the last number of years. And so some of it's on hard copy, or all of it is hard copy, and then some of it's entered into specific databases for various reasons.
And does the people filling these paper forms are trained on how to appropriately fill the paper forms? Do they receive any kind of training for that?
Yeah, I mean, that's part of their standard of care that they've had for many years. So they're used to filling out those forms. How complete is it is a totally different question. Because if they're really busy with that particular patient, or the patient's really sick, then they try to catch up on the paperwork after they take the patient to the hospital. So they fill out a lot of the forms, once they hand it over the patient. But even then, how it should still be fairly accurate. They're not going very far. It's not like they're doing it the next week. They're doing it at the end of that patient episode. So there's not, and we didn't dramatically change it, that it would be difficult to continue doing what they were doing. It's just that some of the terms are in different places. So that in itself, in my mind, wouldn't dramatically change the usage, but maybe it did. Maybe it was harder to indicate where they were giving fluids compared to the previous. Maybe it was just a data collection error. I don't know. So, and because it was not a dramatic change in the flow sheet, I don't know how much time we really spent training them on it. They certainly got to see it and give input. I don't remember how much time we actually spent training them with it. So that's a good question. That's certainly a limitation we would have to put down in any papers. Maybe we didn't spend enough time training them on how to collect that data. And the changes are too much, at the same time.
Yeah, just wondering, because sometimes and it might be an issue, right? If they are, as you said, if they are already busy with the patient and everything they are doing, it can be difficult to fill out information, and maybe if they leave it for afterwards, it's probable that they forget something or something like that. So maybe doing also, as Laura said, for the flow charts, making the collection tool as easy as possible, and to ensure that the information being collected is accurate. And
and to Dennis's point, it may have been accurate at the beginning of that 6-month period. It may have worsened over time. We just have a mean or a median across that time period, and so maybe there are some more subtle changes that we're just not picking up in this broader look, or maybe it didn't work the entire time. I don't know, but I think that's another question. So.
Yeah, I think you could make an argument that, well, maybe they got better at filling it out as time went on, or they just got, more worn out by it as time went on. And I think that idea of like patient severity is interesting, and I'll try to, see if I can compare, if the patients were missing, and I think it's interesting that you brought up, does the form say that they didn't give fluids, or is the box where they would have said that they gave fluids just empty, and it's mostly empty as it, but it's, you know, I'll look again, but I think it's usually like the space is empty and I take it that they didn't give fluid.
Yeah.
But maybe, you know, there's patterns with that missing data with severity of patient's illness or whatnot. I'll see if there's any patterns with that, I guess. But the ends aren't, you know, the overall ends aren't huge. And
Yeah.
I think overall, it looks like you could say that obviously that this checklist was a helpful thing. And that maybe, like you said, there were a lot of complicating factors sort of mediating its effect, but
Mhm.
I'm not sure. That's why I would love to just talk to somebody who used it, who could say like, oh yeah, I hated it, or I loved it, you know, and like
Yeah.
that would
Yeah.
maybe bias me, but kind of just lend sort of the proper perspective for these quantitative results. So I don't.
Yeah, we'll have a quick meeting tomorrow. We probably will end up having some more meetings, and we may end up having to have some of the staff go back and look at some of the data. If there weren't, if the sample size is not huge, they can potentially go back and double check some of that data. Especially.
Okay. Yeah. No,
So, I just have to find money to pay them. So that's the only complexity. But yeah, take a look.
oh, cool.
All right, well, that's sort of that project. Any other thoughts or comments? Okay. All right. Okay, well then that's pretty much it for today then. If we don't have any other comments, we'll plan on meeting next week. Yeah. Okay.
Awesome.
well,
Thanks so much for everyone's attention. I appreciate it.
Yeah, all right, good discussion. All right, see you next week.
Bye. Thank you.